Welcome to this deep dive into the world of ophthalmology, all about the eye and how it works. We're going to be looking at a book called Sme Art Ophthalmology today.
Hmm.
It's specifically designed for people who are getting ready for Indian ophthalmology exams.
Right.
So it has topic-wise questions and answers. It goes over past exam questions from SIA, Osmania, and Falcon,
Hmm.
and it's all updated through 2022. So it's really good if you're studying for those exams.
Definitely. It's a great resource to have on hand.
Okay, so let's jump in. One of the most fundamental concepts in ophthalmology is the visual field. It's something we experience constantly, but we probably don't give it much thought.
Yeah, you're right. The visual field is basically everything you can see around you without moving your eyes.
Okay.
It's that whole 3D area that you can see at any given time. And it's often described as this an island of vision surrounded by a sea of blindness.
Oh, I like that. That's a good way to put it. So you have this limited area you can actually see, and then there's this whole vast expanse that you can't see.
Exactly. And within that visual field that you can see, you've got different types of vision. There's your central vision, which is that really sharp, focused area right in the middle.
Yeah, exactly.
And then there's your peripheral vision, which is everything around it. Peripheral vision isn't as clear, but it's what gives you that awareness of your surroundings. So it's really important.
Okay. So it's like having a spotlight for focused tasks and then a floodlight for just being aware of what's around you.
Precisely. A perfect analogy.
But how do we actually measure this island of vision? I mean, how do
Yeah.
you map out the boundaries and find those blind spots if there are any?
Well, that's where perimetry comes in. Perimetry is the technique that we use to measure the visual field, and it's essential for diagnosing a whole range of conditions, from glaucoma to retinal diseases to even neurological issues.
Wow. So it's a window into the eye and the brain.
It really is.
Yeah, it's incredible.
And there are different ways to perform perimetry. There's kinetic perimetry, where you use a moving light source.
Oh.
And that tests your ability to see movement in your peripheral vision.
So you're tracking a moving target in your side vision.
Precisely. And then there's static perimetry, where the light source stays still, but it changes in brightness.
Okay.
And that tests your sensitivity to light at different points in your visual field.
So it's checking how well you can detect those little changes in light.
Exactly. And then over the years, perimetry has become increasingly sophisticated. We have all these automated systems now, like the Humphreys Automated Analyzer,
Okay.
which offer greater accuracy. They allow us to store the data and compare it to normal values. And it also eliminates any examiner bias.
So it's really improved the accuracy of the testing.
Absolutely. And this has made a huge difference in the way we diagnose and manage eye conditions.
Right.
Perimetry in particular has revolutionized the diagnosis and monitoring of glaucoma, for example.
Okay, speaking of important structures in the eye, Smed Art Ophthalmology goes into the ciliary ganglion, describing it as kind of a relay station for nerve signals.
Oh, that's a great way to put it. The ciliary ganglion is this tiny little structure that's located way back in the bony orbit of the eye. It's like a central hub that gets input from different parts of the nervous system
Okay.
and then sends out signals that control crucial eye functions,
Like what?
like pupil constriction and accommodation, which is the ability of the eye to focus on objects at different distances.
So it's involved in both how much light enters the eye
Yeah.
and how well we focus on objects, both near and far.
Exactly. Imagine this. Light enters the eye through the pupil, that black opening at the center of your iris.
Mm-hmm.
The amount of light that's allowed in is controlled by the sphincter pupillae muscle, which makes the pupil constrict.
Okay.
Then you have the ciliary muscle, which changes the shape of the lens to allow us to focus on near or far objects. And guess what controls both of these muscles?
The ciliary ganglia.
You got it. This tiny little structure is the one that's orchestrating these super precise actions that are essential for clear vision.
So it's receiving input from all those three nerve roots that we were reading about. The sensory root from the nasociliary nerve, the sympathetic root from the internal carotid plexus, and the parasympathetic root from the oculomotor nerve.
Exactly. All that information goes right to the ciliary ganglion, and then signals are sent out through the short ciliary nerves to control the sphincter pupillae for pupil constriction and the ciliary muscle for accommodation.
Okay, so it's like this tiny structure plays a huge role.
It really highlights the interconnectedness of the eye and the nervous system. Even something as simple as constricting your pupil involves this really complex interplay of nerve signals and muscle contraction.
Wow. And this intricate system is something that doctors had to be very aware of, even during procedures like cataract surgery, right?
Absolutely. Before cataract surgery, doctors often block the ciliary ganglion to dilate the pupil. That way, the sphincter pupillae muscle is temporarily paralyzed and the pupil widens, giving the surgeon better access to the cataract.
So understanding the ciliary ganglion and its role in pupil control is really important for surgical procedures.
Definitely. It underscores the importance of these tiny structures for maintaining healthy vision.
Okay, let's switch gears now and talk about a vision problem that's becoming increasingly common. Myopia, or nearsightedness.
Yeah, myopia is definitely on the rise globally. We're kind of seeing a nearsightedness epidemic with more and more people having difficulty seeing things that are far away.
Why is that? What's causing this increase in myopia?
Well, there are a lot of factors at play, like genetics, lifestyle, environment. But one of the biggest culprits seems to be the increased near work that we're all doing.
Near work, so things like reading, using computers, looking at our phones all day.
Exactly. When we spend hours focusing on things close up, it can actually change the shape of our eyes over time.
So our eyes are actually adapting to our modern screen-filled lives.
In a way, yes. And this adaptation can lead to myopia. So in a normal eye, the light rays focus directly on the retina, which is that light-sensitive layer at the back of the eye.
Right, the retina is what sends the signal to the brain so we can see.
Exactly. But in myopia, the eye becomes elongated, which causes light to focus in front of the retina instead of directly on it. And this is what causes those distant objects to appear blurry.
So the image is forming just a little bit in front of where it should be.
Exactly. And that's where glasses or contact lenses come in. They use concave lenses to diverge light rays, basically pushing the focal point back so that it lands right on the retina.
And so it's like they're fine-tuning the way light enters the eye.
Exactly. And for people who are looking for a more permanent solution, there are surgical options available as well.
Like LASIK. I've heard so much about LASIK surgery for vision correction.
LASIK is a very popular option, especially for moderate myopia. It's a corneal-based procedure.
Yep.
It uses a laser to reshape the cornea, which is the clear front part of the eye.
So LASIK is actually reshaping the eye itself to correct the vision.
That's right. By altering the curvature of the cornea, you can change the way light bends as it enters the eye, and that brings those distant objects into focus.
Wow, that's amazing. What are the success rates like for LASIK?
LASIK has a really high success rate. Many patients are able to achieve 20/20 vision or better.
Okay.
But like any surgery, it does come with potential risks and side effects.
Such as?
While some people experience dry eye, halos around lights, or night vision disturbances.
Okay.
But those are usually temporary.
So it's not risk-free, but the potential benefits are pretty significant.
Yeah, that's right. And it's important to remember that LASIK isn't for everyone. It's really important to have a thorough evaluation by an ophthalmologist to determine if it's the right choice for you.
Okay. Are there other surgical options besides LASIK?
Oh, absolutely. There are other corneal-based procedures like PRK and photoablation.
Okay.
And then there are lens-based procedures that involve working on the natural lens inside the eye.
So you can have a procedure that either reshapes the cornea or adjusts the lens.
Exactly. And the best option really depends on each person's specific needs and how severe their myopia is.
What about preventing myopia in the first place? Is there anything people can do to reduce their risk, especially for children?
Absolutely. Spending time outdoors is thought to be really protective against myopia
Oh,
development.
interesting. Why is that?
Well, research suggests that exposure to natural light actually helps regulate eye growth, and that might help reduce the risk of the eye becoming elongated. It also allows the eye muscles to relax, preventing eye strain.
So less screen time, more sunshine for healthy eyes.
Exactly. And it's really important to encourage children to take breaks from near work, to look up and focus on distant objects, and to make sure there's adequate lighting when they're reading or using screens.
So good lighting, regular breaks, and plenty of outdoor time are all important.
They are. And of course, a balanced diet, rich in vitamins and antioxidants, is important for overall health, which includes eye health.
Okay, so we've covered myopia. Let's move on to another common vision problem that often gets mentioned alongside myopia. Astigmatism.
Ah, yes, astigmatism. Astigmatism is all about the shape of the cornea. Instead of being perfectly round like a basketball, imagine the cornea is shaped more like a football.
So it has this uneven curvature.
Exactly. And that uneven curvature causes light to bend differently as it passes through the cornea,
Okay.
which results in blurry or distorted vision.
So instead of a single focal point, the light is kind of scattering in different directions.
Exactly. And this can cause problems seeing clearly at all distances, not just near or far.
So someone with astigmatism might have eye strain, headaches, and difficulty seeing fine details, no matter how far away the object is.
Exactly. And just like with myopia, the solution often involves corrective lenses. Glasses with cylindrical lenses are used to bend the light in a way that compensates for that uneven cornea.
So they're counteracting that irregular bending that's happening because of the astigmatism.
Exactly. And for contact lens wearers, toric lenses are specifically designed to correct astigmatism.
Okay.
They have a weighted bottom that helps them stay in the correct position on the eye, so you're always getting consistent correction.
So they don't just rotate around randomly in your eye.
Right. And then if people are looking for a more permanent solution, there are surgical options for astigmatism as well.
So similar to myopia, there are ways to surgically reshape the cornea to correct astigmatism.
Exactly. LASIK is one option, but there's also a stigmatic keratotomy and phototherapeutic keratoplasty.
What's the difference between those procedures?
Well, they all aim to reshape the cornea, but they use different techniques.
Okay.
LASIK uses a laser. Astigmatic keratotomy involves making these tiny incisions in the cornea. And phototherapeutic keratoplasty uses ultraviolet light to modify the corneal shape.
So it's like different tools in the toolbox, each with its own set of advantages and disadvantages.
Precisely. And the best choice really depends on how severe the astigmatism is, what type it is, and also the individual's overall eye health.
Okay, we've talked about myopia and astigmatism, both of which are refractive errors. So that means the light isn't focusing correctly on the retina. Let's move on now to a vision change that isn't a refractive error, but just a normal part of aging. Presbyopia.
Presbyopia. It's something we all experience as we get older. It's that gradual loss of near vision that comes with age.
So that familiar feeling of needing to hold things farther away to see them clearly, that's presbyopia kicking in.
That's it. And it's not because the eye is shaped wrong. It's because the lens inside the eye loses its flexibility over time.
The lens, that clear structure that helps focus light onto the retina.
Yes. The lens is normally very elastic and can change shape easily to accommodate for near and far vision, but as we age, it gets stiffer and it's harder for it to flex.
So it's like a muscle that gets a bit stiff over time.
A great analogy. And this loss of flexibility makes it harder to focus on those close objects, which leads to blurry near vision.
So in this case, the image is forming behind the retina instead of directly on it.
Exactly. And the solution often involves convex lenses, which converge light rays, helping them focus properly on the retina for those near vision tasks.
So reading glasses are a common solution for presbyopia.
They are. And there are other options like bifocals or progressive lenses, which combine both distance and near correction in one lens.
So you can see clearly at all distances without having to switch glasses.
Exactly. And for those who are looking for a more permanent fix, there are surgical options for presbyopia as well.
Oh, like LASIK.
LASIK is one option, but there are also procedures that involve implanting special lenses like multifocal or accommodating intraocular lenses or IOLs. These lenses actually have different zones for near and far vision, so you can see clearly at multiple distances.
So it's like having built-in bifocals in your eyes.
Exactly. And these lenses can be implanted either during cataract surgery or as a standalone procedure called refractive lens exchange.
Okay, let's switch gears now and talk about something a bit more concerning. Eye infections. The book starts with a condition called ophthalmia neonatorum, which sounds pretty scary.
It's a mouthful of a name, but it's a treatable condition. It's essentially conjunctivitis or inflammation of the conjunctiva that occurs in newborn.
The conjunctiva, that's that clear membrane that lines the inside of the eyelid and covers the white part of the eye. Yeah.
That's right. And in newborns, this inflammation can be caused by bacteria or viruses that they acquire during birth or shortly after.
So the baby picks up those pathogens as it passes through the birth canal.
That's one way it can happen. But it can also happen after birth through contact with contaminated hands or surfaces.
What are the most common causes of ophthalmia neonatorum?
The most common culprits are bacteria, Neisseria gonorrhea and Chlamydia trachomatis. Both of those can be passed from mother to baby during childbirth.
And those are sexually transmitted infections, right?
They are.
So it's super important for pregnant women to be screened and treated to prevent spreading it to their babies.
Absolutely. Prenatal care and screening are absolutely essential for preventing ophthalmia neonatorum.
And what about during and after birth? Are there any preventative measures taken then as well?
Yes, proper hygiene during childbirth is really important. And in many countries, newborns are given antibiotic eye drops shortly after birth as a preventative measure.
So even if they're exposed to those bacteria, the antibiotics can prevent an infection.
Exactly. It's a very effective way to reduce the incidence of this condition.
What are the signs and symptoms of ophthalmia neonatorum?
Well, typically you'll see redness and swelling of the conjunctiva,
Okay.
and there may be some discharge from the eye as well.
So a red, irritated eye that might have some goopy discharge.
Yeah, pretty much.
Yeah.
And the timing of the symptoms can actually give us clues about what's causing it. For example, if the symptoms appear within a few hours of birth, it's more likely to be chemical conjunctivitis.
Oh, from like the silver nitrate drops they used to use.
Right, a reaction to the eye drops themselves.
Oh.
But if the symptoms appear a few days after birth, then it's more likely to be bacterial conjunctivitis.
Caused by those bacteria we were talking about.
Exactly, so the timing can help us narrow things down.
Okay, what about treatment? How do you manage ophthalmia neonatorum?
The first step is to identify the specific bacteria causing the infection. So we take a sample of that discharge and we culture it to find out what it is.
Okay, so they grow the bacteria in a lab to figure out exactly what it is.
Exactly. And once we know which bacteria it is, then we can prescribe the right antibiotics.
Okay.
We also use saline washes to help clean the eye and remove the discharge.
So antibiotics and keeping the eye clean are the mainstays of treatment.
They are. And with prompt treatment, ophthalmia neonatorum resolves really quickly in most cases.
That's good to hear. Okay, let's move on to another infection that's a major public health concern worldwide, trachoma.
Trachoma is a devastating disease, especially when you consider that it's totally preventable and treatable in its early stages.
The book says it's the world's leading infectious cause of blindness. That's pretty sobering.
It really is. And what's even more tragic is that it mostly affects impoverished communities in developing countries where there's limited access to healthcare and sanitation.
So it's a disease of poverty and inequality.
Sadly, yes. And it's caused by that same bacteria that can cause ophthalmia neonatorum, chlamydia trachomatis.
That little bacteria is sure causing a lot of trouble. But in the case of trachoma, it causes chronic keratoconjunctivitis, right?
That's right. Both the cornea and the conjunctiva are affected. And what makes trachoma so dangerous is that it's not just a one-time infection. It progresses in stages.
So it's an ongoing chronic process.
Exactly. The initial infection is called the active phase, and that causes conjunctivitis,
Okay.
with redness, discharge, and the development of these little bumps on the conjunctiva called follicles.
And if this active phase isn't treated, then it can progress to a scarring phase.
Exactly. Repeated inflammation leads to scarring of the conjunctiva, which then affects other structures in the eye.
What kind of domino effect are we talking about here?
Well, a common complication is something called trichiasis.
Trichiasis, what is that?
Trichiasis is when the eyelashes turn inward and start rubbing against the cornea.
Ouch. That sounds incredibly painful and irritating.
It is. And that constant rubbing can lead to corneal ulcers, scarring, and ultimately vision loss.
Wow, so the scarring from the trachoma can actually change the direction that the eyelashes grow in.
It really highlights how insidious this disease can be.
Right.
And then another complication is corneal opacity. So that's where the cornea loses its transparency and becomes cloudy.
So trachoma can really attack the eye on multiple fronts: inflammation, scarring, and damage to both the conjunctiva and the cornea.
It's a multifaceted disease.
Right.
But the good news is that we have effective treatments for it. Antibiotics like tetracycline or azithromycin are used to target the chlamydia trachomatis bacteria.
So similar to ophthalmia neonatorum, antibiotics are the first line of defense.
Exactly. And for complications like trichiasis, surgery might be necessary to reposition the eyelashes so they're not rubbing against the cornea.
Okay, so antibiotics for the infection, surgery to address complications.
Mm-hmm.
What about preventing it in the first place? Is there a way to stop trachoma from spreading?
Absolutely. The World Health Organization has this comprehensive strategy called SAFE that focuses on the prevention and control of trachoma.
SAFE. That's easy to remember. What does it stand for?
It stands for surgery for trichiasis, antibiotics to treat the infection, facial cleanliness to prevent the spread, and environmental improvement, which basically means access to clean water and sanitation.
So it's a multifaceted approach, recognizing that both hygiene and environmental factors play a huge role in the spread of trachoma.
Exactly. It's a reminder that healthcare is not just about treating individuals, it's also about addressing those social and environmental determinants of health.
Okay, let's move on to another type of conjunctivitis that has a very specific trigger.
Yeah.
Allergies.
Yes, vernal keratoconjunctivitis, or VKC for short.
Right.
It's an allergic inflammation of the conjunctiva. And it's often seasonal, which is why it's nicknamed spring catarrh.
So pollen, dust mites, all those good things.
Exactly. And people with a family history of allergies or atopy are more prone to developing VKC.
Atopia, so that's just a predisposition to allergies like hay fever, eczema, or asthma.
Right. So if you have any of those conditions, you might be more susceptible to VKC as well.
So what happens in the eye when someone with VKC is exposed to their allergens? What's going on at the cellular level?
Well, basically, those allergens trigger an immune response in the conjunctiva, and that leads to inflammation, redness, and intense itching. It can feel like you have something stuck in your eye, and the itching can be unrelenting.
I can imagine. That sounds awful. And there are actually different forms of VKC depending on what part of the eye is affected, right?
That's right. There's the palpebral form, which mainly affects the eyelids.
Okay.
And you'll see these really characteristic cobblestone papillae on the upper eyelid. It almost looks like a bumpy cobblestone street.
Wow. That's quite the image. And then there's the bulbar form, which affects the conjunctiva that's on the eyeball itself.
Exactly. The white part of the eye gets red and irritated. And sometimes there's a mixed form where both the eyelid and the bulbar conjunctiva are involved.
So it could be quite a widespread problem.
It can be, yes.
How is VKC treated? Is it similar to other types of conjunctivitis?
The treatment really depends on how bad the symptoms are and how the person responds to different medications. But generally, the first thing we try to do is avoid those triggers.
Well, that's easier said than done, especially with something like pollen. You can't exactly stay inside all spring.
That's true. So in addition to allergen avoidance, we often use cold compresses just to soothe that inflammation and give some relief from the itching and burning.
So just a cool washcloth on the eyes.
Exactly. And we can also prescribe topical medications like antihistamines, mast cell stabilizers, and even corticosteroids for more severe cases.
So a combination approach depending on the individual's needs.
Exactly. And the good news is that for most people, VKC is a manageable condition. It might be annoying, but it rarely causes any lasting damage to the eye.
Okay, good. Let's move on now to a condition that, while it's usually harmless, it can look really alarming. Subconjunctival hemorrhage.
Ah, yes, the classic red eye that can make people freak out and run to the doctor.
Right.
But in most cases, it's not serious at all. It's just a tiny blood vessel that's broken under the conjunctiva, which causes that bright red patch on the white of the eye.
So it's essentially like a bruise on the eye.
That's a good way to think about it. And usually it's caused by something as simple as rubbing your eyes too hard.
Really? Something that small can cause that?
It can, especially if you have fragile blood vessels.
Yeah.
And anything that increases pressure in the head can also do it, like coughing, sneezing, or even straining during a bowel movement.
So any activity that causes a sudden increase in pressure.
Exactly. And in some cases, bleeding disorders can also contribute to a subconjunctival hemorrhage.
So if someone bruises easily, or they have a history of blood clotting problems, they might be more susceptible to these eye bleeds.
Exactly. But again, in most cases, it's harmless and goes away on its own within a week or two without any treatment.
So more of a cosmetic concern than a real medical problem for most people.
For most people, yes. But it's always a good idea to see your eye doctor if you experience this, just to rule out any other underlying condition.
Okay. Speaking of location, there's a type of conjunctivitis that specifically affects the corners of the eyes. Angular conjunctivitis.
Yes, angular conjunctivitis. It's often caused by this bacteria called Moraxella axenfeld. And as you said, it typically affects the corners of the eyes, right where the eyelids meet.
And there's a connection between this condition and nasal health, right?
There is. It's believed that the bacteria can actually spread from the nose to the eyes, particularly if there's some kind of blockage or inflammation in the tear ducts.
The two ducts drain tears from the eyes into the nose, right?
Exactly.
So if those aren't functioning properly, it can create a perfect little environment for bacteria to grow.
Exactly. You'll see redness and irritation in the corners of the eyes and maybe some sticky discharge.
So what's the treatment for angular conjunctivitis?
Well, antibiotics are the main treatment to target that Moraxella axenfeld bacteria.
So antibiotic eye drops, I'm assuming.
Yes, usually in the form of drops or ointment. And sometimes we use zinc ointment as well.
Zinc ointment. Why zinc?
Zinc has antibacterial properties,
Okay.
but it can also help soothe the skin and reduce irritation.
So it's a multi-purpose treatment.
Exactly. And of course, it's really important to address any underlying nasal issues that might be contributing. So if there's a chronic nasal infection or inflammation, that needs to be treated to prevent the angular conjunctivitis from coming back.
Okay, let's move on to another form of conjunctivitis that has a very descriptive name. Follicular conjunctivitis.
Ah, follicular conjunctivitis. This one's named for those little bumps or follicles that appear on the conjunctiva.
And we've talked about follicles before in the context of trachoma, right?
We have, yes. But it's important to remember that follicular conjunctivitis doesn't cause scarring like trachoma does.
Okay, that's an important distinction. So what causes those follicles to form in follicular conjunctivitis?
It's basically a response to inflammation. And the inflammation can be triggered by various things like viruses, bacteria, and even allergens.
So it's kind of a catch-all term for any conjunctivitis that involve those follicular bumps,
You can think of it that way.
right?
And the specific cause will often determine what treatment is needed.
So if it's bacterial, they'll use antibiotics. If it's viral, they might just recommend supportive care like cool compresses.
Exactly. And thankfully, most cases of follicular conjunctivitis will resolve on their own with time.
Okay, that's good to know. Let's delve back into the realm of the retina now. The book discusses diabetic retinopathy, a serious complication that can arise from diabetes.
Yes, diabetic retinopathy is a major concern for people with diabetes. It's one of the leading causes of vision loss in adults.
Wow.
And it all comes down to the damage that high blood sugar levels can cause to the tiny blood vessels in the retina.
It seems like those retinal blood vessels are pretty vulnerable.
They're delicate, and they're essential for delivering oxygen and nutrients to the retina. But when your blood sugar is high, it can damage the walls of those blood vessels, making them weak and leaky.
So it's like high blood sugar is slowly eroding those vessels.
That's a good way to put it. And this damage can cause a cascade of problems.
Okay.
In the early stages, which we call non-proliferative diabetic retinopathy, you'll see things like microaneurysms,
Okay.
which are tiny little bulges in the capillary walls, almost like miniature aneurysms. You might also see what we call dot and blot hemorrhages. These are small areas of bleeding from those weakened vessels.
So tiny little leaks and bleeds within the retina.
Exactly. And as the condition progresses, you may see hard exudates, which are lipid deposits that build up in the retina.
So high blood sugar is causing all these little changes in the vessels, leading to leaks, bleeds, and deposits.
Exactly. And if non-proliferative diabetic retinopathy isn't managed properly, it can advance to a more serious stage called proliferative diabetic retinopathy.
Proliferative, so that means something's proliferating or growing.
You got it. At this stage, the retina is so starved for oxygen because of those damaged blood vessels that it actually starts to grow new blood vessels to try to compensate. It is. But unfortunately, these new vessels are abnormal and fragile, and they can bleed easily. And those bleeds can lead to some really serious complications, like retinal detachment.
Retinal detachment, that's when the retina actually peels away from the back of the eye, right?
Yes. And it's considered a sight-threatening emergency, so it needs immediate attention.
Okay, so diabetic retinopathy is a serious business. It starts with those blood vessel changes. Then it progresses to abnormal blood vessel growth. And then ultimately, it can lead to retinal detachment and vision loss.
That's a good summary. So how do we manage diabetic retinopathy? What can we do to slow this process down or even stop it?
Well, I'm guessing that controlling blood sugar is a key part of it.
It's absolutely crucial. Keeping those blood sugar levels in a healthy range can drastically reduce the risk of even developing diabetic retinopathy. And it can also slow down the progression if it's already there.
So good diabetes management is really essential for protecting your eye health.
Absolutely. And regular eye exams are super important too for early detection and timely treatment.
How often should people with diabetes see their eye doctor?
It depends on the individual person and how severe their retinopathy is. But generally, at least once a year, sometimes more often.
And even if they don't notice any vision changes, those regular checkups are still important, right?
They are. Early detection is key because there are treatments that can help preserve vision.
What kind of treatments are we talking about?
Well, we have laser therapy, which can seal leaking blood vessels or shrink abnormal ones. And then there are also injections that can be given directly into the eye.
Injections into the eye. That sounds a little scary.
It might sound intimidating, but it's a very safe and effective procedure. And the injections contain medications that can reduce swelling in the retina and slow down the growth of those abnormal blood vessels.
So it's a combination of controlling blood sugar, having those regular eye exams, and then these targeted treatments to help manage diabetic retinopathy.
Exactly. And the earlier we can intervene, the better the chances of a good outcome.
Okay, let's move on to another retinal condition, one that has a pretty alarming name, retinoblastoma.
Retinoblastoma is a rare type of eye cancer that mainly affects young children.
Oh, wow.
It arises from the neurosensory retina, that's the light-sensitive layer at the back of the eye.
Childhood eye cancer, that's just heartbreaking. What causes retinoblastoma?
It's caused by a genetic mutation, which can either be inherited from a parent or it can occur spontaneously.
So if a parent has retinoblastoma, their child has a higher risk.
Yes, but in most cases, the mutation just happens randomly without any family history.
And this mutation causes a tumor to grow within the retina.
Exactly. And one of the hallmarks of retinoblastoma is something called leukocoria, which is a white pupillary reflex.
The pupillary reflex, that's that red glow you often see in photos when the flash is used, right?
Yes. In retinoblastoma, instead of seeing that red reflex, you see a white one. It's caused by the tumor reflecting the light back differently.
So if you see a white glow in your child eye in a photo, that's a serious red flag.
Absolutely. You should see an eye doctor right away.
What are some of the other symptoms of retinoblastoma?
Well, it really depends on the tumor, how big it is, and where it is. Sometimes there might not even be any noticeable symptoms in the early stages. But as the tumor grows, it can cause problems with vision, like blurry or double vision. Sometimes it causes strabismus, which is a misalignment of the eyes. And it can also cause pain and redness in the eye.
So a whole variety of symptoms that could be mistaken for other eye conditions.
Exactly. That's why it's so important to take any unusual eye symptoms in children seriously.
What are the treatment options for retinoblastoma?
That depends on several factors, like the size and location of the tumor, whether it's spread, and the child's overall health.
So a very individualized approach.
It is. What are some of the treatment options? Well, there's enucleation, which means surgically removing the eye.
I can imagine that's a really difficult decision.
It is, but sometimes it's the best option to prevent the cancer from spreading.
Are there less invasive options available as well?
Fortunately, yes. Radiation therapy is often used to shrink the tumor.
So using targeted beams of radiation to kill those cancer cells.
Exactly. And we can also use chemotherapy, which uses drugs to kill the cancer cells throughout the body.
So similar to how other types of cancers are treated, are there any treatments specifically for the eye?
Yes, sometimes we can use laser therapy to destroy small tumors.
So they have a whole range of tools to use, and the choice depends on the situation.
That's right.
It must be a really tough journey for families who are facing this diagnosis.
It is. But the good news is that the survival rate for retinoblastoma is very high, especially with early detection.
Okay, let's move on to another retinal condition, one that we touched on earlier when we were talking about diabetic retinopathy. Retinal detachment?
Retinal detachment is an ophthalmologic emergency. It's when that light-sensitive layer at the back of the eye, the neurosensory retina, detaches from the underlying layer. It's like wallpaper peeling off a wall.
That's a vivid analogy. And this separation can happen in a few different ways, right?
Yes, there are three main types of retinal detachment: rhegmatogenous, tractional, and exudative.
Rhegmatogenous, that one sounds kind of intimidating. What does it mean?
It means there's a tear or a hole in the retina. Think of it like a little rip or a puncture. And this allows fluid to seep underneath and lift the retina away from its attachment.
So like an air bubble forming under wallpaper, causing it to lift up.
Exactly. And those tears or holes can be caused by a number of things like trauma, nearsightedness, or even just age-related changes in the vitreous humor, that gel-like substance that fills the back of the eye.
So a lot of different things can cause those tears to form. What about tractional retinal detachment? What causes that type?
In tractional retinal detachment, scar tissue forms on the surface of the retina, and that scar tissue pulls the retina away from its attachment.
So the scar tissue is kind of acting like glue, tugging on the retina.
Exactly. And we often see this type of detachment in people with diabetic retinopathy. Remember those abnormal blood vessels we talked about? Well, they can leak and cause scar tissue to form, and that scar tissue can then lead to tractional retinal detachment.
Yet another reason to keep that blood sugar under control. Okay, what about the third type, exudative retinal detachment?
In exudative retinal detachment, fluid builds up under the retina, but there isn't a tear or a hole.
So no puncture wound, but fluid is still accumulating and pushing the retina away.
Precisely. And this fluid buildup can be caused by several things, like inflammation, tumors, or even certain medications.
Okay, so we have the three main types. One with a tear, one with scar tissue pulling, and one with fluid buildup. What are the symptoms of retinal detachment? What would someone experience if this was happening?
The classic symptoms are floaters, flashes of light, and a curtain-like shadow that descends over your vision.
Floaters, those little specks or strands that drift across your vision. I thought those were usually harmless.
They are, in most cases. But a sudden increase in floaters, especially if you're also seeing flashes of light, can be a sign of retinal detachment.
So it's the combination of symptoms and how suddenly they appear that's concerning?
Exactly. And then there's that curtain-like shadow. As the retina detaches, it can block light from reaching certain parts of the eye, so it creates this shadow that seems to be moving down over your vision.
That sounds scary.
It is, and it's incredibly important to seek immediate medical attention if you experience any of these symptoms.
If you start seeing cobwebs or lightning strikes in your vision and then a dark curtain starts to come down, get to an eye doctor right away.
Absolutely. Time is critical with retinal detachment. The longer the retina stays detached, the higher the risk of permanent vision loss.
Okay, let's talk about treatment. How is a detached retina repaired?
Well, the treatment really depends on the type of detachment and how severe it is. For rhegmatogenous detachments, the ones caused by a tear, the goal is to seal that tear up and prevent more fluid from leaking underneath.
And how do they do that?
We can use laser surgery or cryotherapy to create a scar around the tear, basically welding it shut.
So using either heat or cold to seal the leak.
Exactly. And sometimes we do a procedure called a scleral buckle, where we attach this little silicone band to the outside of the eye.
Okay.
And that band indents the wall of the eye, pushing it back into contact with the detached retina so it can reattach.
So they're actually buckling the sclera to help the retina reattach.
Yeah.
What about tractional detachments, the ones caused by scar tissue?
For those, we often do a vitrectomy, where we remove the vitreous humor and replace it with a clear fluid or a gas.
Okay.
And that helps relieve the pull on the retina that's being caused by the scar tissue.
So taking out that gel-like substance and replacing it with something that won't tug on the retina.
Exactly. And for exudative detachments, the ones caused by fluid buildup, the focus is on treating whatever is causing that fluid to accumulate in the first place. So if it's inflammation, we might use steroids. If it's a tumor, we might recommend surgery or radiation. The goal is to stop that fluid from building up and pushing the retina away.
Okay, so different treatment options depending on what type of detachment it is and what caused it. But the bottom line is, if you have any sudden vision changes, especially those we talked about, get to a doctor right away.
Absolutely. Early diagnosis and treatment are essential for saving your vision.
Okay, let's shift gears now and talk about a condition that's not an acute emergency like retinal detachment, but is more of a chronic progressive eye disease. Retinitis pigmentosa.
Retinitis pigmentosa, or RP, is a group of inherited diseases that cause gradual vision loss. It primarily affects the rods, which are the photoreceptor cells in the retina that are responsible for night vision and peripheral vision.
So the cells that help us see in low light and detect movement off to the sides.
Exactly. And in RP, these rod cells gradually degenerate and die off, which leads to the classic symptoms of the disease.
What are those classic symptoms?
Well, the first symptom people usually notice is night blindness, or difficulty seeing in low light.
So someone with RP might have trouble navigating a dimly lit room or driving at night.
Exactly. And as the disease progresses, their peripheral vision starts to deteriorate as well. This leads to what we call tunnel vision, where their field of view becomes increasingly narrow.
So it's like looking through a tunnel. You lose that awareness of what's around you in your peripheral vision.
Precisely. And eventually, even their central vision can be affected in the later stages of the disease.
So RP starts by affecting those rods, impacting night and peripheral vision, and then it can eventually progress to central vision loss. That sounds incredibly challenging to live with.
It can be. And there's no cure for RP at this time, which can be very frustrating for patients and their families.
No cure at all. So it's like a life sentence of progressive vision loss.
There's no cure yet, but there are things we can do to help manage the symptoms, slow down the progression of the disease, and improve the person's quality of life.
Like what?
Well, genetic testing and counseling are very important for people who have a family history of RP.
So understanding how it's inherited can help families make decisions about family planning.
Exactly. And for people who have already been diagnosed, we have low vision aids, like magnifiers, special lighting, and computer software that can enlarge text and images.
So making the most of whatever vision they have left and helping them adapt to the changes.
Right. And then there's a lot of exciting research going on in the field of RP.
Okay.
Gene therapy and stem cell therapy are two areas that hold a lot of promise.
So potentially replacing those damaged rod cells with healthy ones.
That's the hope. There's a lot of optimism that someday we'll be able to offer even more effective treatments and maybe even a cure for this very challenging disease.
Let's move on to another condition that, like diabetic retinopathy, is a consequence of a systemic disease. Hypertensive retinopathy.
Hypertensive retinopathy is damage to the retina that's caused by high blood pressure or hypertension. It's another example of how our overall health can directly affect our eyes.
High blood pressure is often called the silent killer because it can cause damage all over the body without any noticeable symptoms.
It's right. And the eyes are often one of the first places we see the effects of high blood pressure that's not being managed.
So those tiny blood vessels in the retina are taking a hit from all that extra pressure.
Exactly. And just like with diabetic retinopathy, damage to those vessels can lead to a whole bunch of problems, like leaking, bleeding, and even the growth of those abnormal blood vessels.
So the symptoms can be similar to diabetic retinopathy.
They can be. And just like with diabetic retinopathy, there's a grading system for hypertensive retinopathy based on how much damage there is.
The grading system. Okay.
Yeah.
What are the different grades?
Well, grade 1 is the mildest form, where we might see some slight narrowing of the retinal arterioles, which are the small arteries that supply blood to the retina.
So that high blood pressure is causing those arteries to squeeze down.
Yes, think of it like squeezing a garden hose. It restricts the blood flow.
What about grade 2? How is that different?
In grade 2, the narrowing of the arterioles is more noticeable, and we also start to see something called AV nicking.
AV nicking, what's that?
That's where those constricted arteries, the arterioles, cross over the veins in the retina, and they actually put a little dent in them.
So the arteries are actually pressing down on the veins.
They are. It's a sign that the blood flow is being disrupted.
Okay, what about grade 3? What happens when hypertensive retinopathy reaches that stage?
Grade 3 is where things start to get more serious. Along with the arteriolar narrowing and the AV nicking, we might start seeing things like cotton wool spots, which are these fluffy white areas that indicate nerve fiber damage. We might also see flame-shaped hemorrhages, which are bleeds from those damaged blood vessels. And we might even see hard exudates, those lipid deposits that we talked about earlier.
So the same kinds of findings we discussed with diabetic retinopathy?
That's right. They can occur in both conditions, and they're a sign that the retina is being damaged.
And then grade 4 is the most severe form.
Yes, grade 4 is when we see papilledema.
Papilledema, what is that exactly?
Papilledema is swelling of the optic disc, which is the head of the optic nerve.
So now the swelling is actually affecting the optic nerve itself.
It is, and that's a sign that the blood pressure is very high and not being controlled. It can lead to permanent vision loss if it's not addressed.
Okay, so the takeaway here is high blood pressure can damage the eyes, and the longer it goes untreated, the greater the risk of serious vision problems.
Exactly. Managing your blood pressure is crucial, not just for your heart and kidneys, but for your eyes as well.
Let's move on to another condition that can disrupt blood flow in the retina: central retinal vein occlusion.
Central retinal vein occlusion, or CRVO, is sometimes called a stroke in the eye. It happens when the central retinal vein, which is the main vein that drains blood from the retina, gets blocked.
So instead of the blood flowing out of the retina, it gets backed up.
Exactly. And that blockage can trigger a whole cascade of problems that can damage the retina.
What kind of cascade are we talking about?
Well, when the vein gets blocked, the pressure builds up in the smaller veins and capillaries behind it.
So it's like a traffic jam in those tiny blood vessels.
That's a great way to put it. And that increased pressure forces fluid to leak out from those vessels, and that causes swelling in the retina. We call that macular edema, and it can really distort vision.
And what about those tiny blood vessels themselves? What happens to them when they're under all that pressure?
They can get damaged, and sometimes they even rupture. This causes bleeding into the retina, so it's a combination of fluid leakage and bleeding that damages the retinal tissue.
And the severity of all this depends on how blocked the vein is.
Exactly. We generally classify CRVO as either ischemic or non-ischemic.
What's the difference between those two?
Ischemic CRVO is the more severe form. It's where there's a major blockage, and it cuts off most of the blood flow, or ischemia, to a large part of the retina. It's like that part of the retina is being starved of oxygen and nutrients.
In non-ischemic CRVO.
In non-ischemic CRVO, the blockage isn't as complete. There's still some blood flow getting to the retina, so the damage isn't usually as bad.
So the chances of the vision getting better are higher in the non-ischemic type.
Generally, yes. And the main symptom of CRVO, no matter which type it is painless vision loss.
Painless. So some could just wake up one morning and their vision is blurry or distorted, but they don't feel any pain or discomfort.
That's a pretty common scenario, and it's crucial to seek medical attention right away if that happens.
So don't wait and see if it gets better on its own.
Exactly. Early diagnosis is key to figure out what type of CRVO it is and to decide what the best treatment is.
So how is CRVO treated?
Well, for ischemic CRVO, the goal is to get the blood flowing again in the retina as quickly as possible. Sometimes we use medications that can break down blood clots, and we often do a procedure called laser photocoagulation.
That's where they use a laser to make tiny burns in the retina, right?
Exactly. It helps shrink those abnormal blood vessels and reduce the swelling. And for non-ischemic CRVO, the focus is often on managing the complications, like the macular edema we talked about.
So those injections we talked about earlier, the anti-VEGF medications, could be used to reduce that swelling in the macula.
Exactly. And sometimes we use laser therapy for non-ischemic CRVO as well.
Okay, let's shift gears now and talk more about the cornea. We've talked about conjunctivitis, which affects that clear membrane over the white part of the eye. But what about infections that affect the cornea itself?
Corneal infections are a big concern because the cornea is the clear, dome-shaped front part of the eye that helps focus light. Any damage to the cornea can have a direct impact on vision.
And one of the most common types of corneal infection is a bacterial corneal ulcer, right?
That's right. A bacterial corneal ulcer is basically an open sore on the cornea that's caused by bacteria.
So like a skin ulcer, but on the eye.
Exactly. And just like skin ulcers, they can vary in size and depth. Some are superficial, while others are deeper and more serious.
And I imagine they could be quite painful.
They can be. People with bacterial corneal ulcers often have sharp, stabbing pain that gets worse when they blink. They might also have redness, tearing, and some discharge from the eye, and sensitivity to light.
So bright lights would be uncomfortable.
Yes, we call that photophobia. And of course, the defining feature of a corneal ulcer is the ulcer itself, which can look like a white or gray spot on the cornea.
So how do those bacteria get into the cornea and cause an ulcer?
Yeah.
I thought the cornea was usually pretty good at fighting off infections.
It is, but any damage to the surface of the cornea can create an entry point for bacteria.
So things like scratches or abrasions or even dry eye.
Exactly. Contact lens wear, trauma, foreign objects in the eye, even something like dry eye can all disrupt the surface of the cornea and make it more vulnerable to infection.
And once the bacteria get in, they can multiply and cause inflammation and damage.
That's right. And if it's not treated, a bacterial corneal ulcer can lead to scarring, vision loss, and even perforation of the cornea.
Perforation, so like a hole through the cornea.
Yes, that's a serious complication that can cause blindness if it's not addressed quickly.
So treating those ulcers quickly and effectively is super important.
Absolutely. Antibiotics are the main treatment. We use antibiotic eye drops that are often fortified to penetrate the corneal tissue better. Sometimes we also use cycloplegic eye drops to reduce pain and inflammation. And in some cases, we might need to do a corneal scraping to get a sample of the infected tissue so we can culture it and make sure we're using the right antibiotic.
So they're taking a little swab of the ulcer and growing the bacteria in a lab to figure out what it is.
Exactly. And if the ulcer is really deep or it's not responding to the initial treatment, a corneal transplant might be necessary.
So that's a last resort.
It is. But the good news is that with the right treatment, and if it's caught early enough, most corneal ulcers heal without any long-term problems.
Okay, let's talk about another corneal condition that has a pretty simple name. Corneal edema.
Corneal edema is just swelling of the cornea that's caused by a buildup of fluid.
So instead of being clear, the cornea gets cloudy and swollen?
Exactly. Imagine a sponge that's full of water. That's kind of what the cornea looks like when it has edema.
And I'm guessing that cloudiness and swelling would make it hard to see.
Absolutely. People with corneal edema often describe their vision as blurry or hazy. They might see halos around lights. And sometimes it can even be painful.
So what causes this fluid to build up in the cornea? I thought the cornea was supposed to be pretty dry.
It is. But it normally maintains a balance of fluid with factors that draw water in and factors that pump water out.
So it's constantly trying to stay hydrated, but not too hydrated.
That's a good way to put it. And corneal edema happens when something messes up that balance and the cornea starts to retain too much fluid.
What kind of things can disrupt that balance?
Well, one common culprit is increased intraocular pressure, or IOP.
IOP. That's the pressure inside the eye.
Exactly. And elevated IOP is what we see in glaucoma.
Glaucoma, that's the condition that damages the optic nerve, right?
That's right. And that damage is often caused by increased IOP, which can also cause corneal edema.
So glaucoma can affect both the optic nerve and the cornea.
It can. Another cause of corneal edema is damage to the endothelium, which is the innermost layer of the cornea.
Remind me what the endothelium does again?
The endothelium is basically a little pump that removes fluid from the cornea, keeping it clear and at a normal thickness.
So if the endothelium is damaged, He can't pump out the fluid, and that's what leads to the fluid buildup and edema.
Exactly.
And what are some things that can damage the endothelium?
There are lots of things, actually. Eye surgery, trauma, some medications, and even certain genetic conditions.
Okay, so increased IOP and endothelial damage are two causes of corneal edema. Are there any others?
Yes, inflammation can also cause corneal edema uveitis, for example, which is inflammation inside the eye, can lead to fluid building up in the cornea.
Okay, so increased IOP, endothelial damage, and inflammation are the three main culprits. What about treatment? How do you manage corneal edema?
Well, the first step is always to figure out what's causing it and treat the underlying problem.
So if it's glaucoma, treating the glaucoma would be the top priority.
Exactly. And if it's endothelial damage, we might recommend certain medications or procedures, but there are also treatments that target the edema itself.
Like what?
One common approach is to use something called hyperosmotic agents.
Hyperosmotic agents? What are those?
They're eye drops that draw water out of the cornea, so they help reduce the swelling.
So they're basically dehydrating the cornea.
You could think of it that way. They create this concentration gradient that pulls the excess fluid out.
Clever. What other medications might be used?
We can use steroid eye drops to reduce inflammation, especially if the edema is caused by something like uveitis.
So we have the hyperosmotic agents to remove fluid and the steroid drops to reduce inflammation. What if those treatments don't work? Is a corneal transplant an option?
It is, yes.
Yeah.
If the cornea is severely damaged and doesn't respond to other treatments, we might have to do a corneal transplant, also called a keratoplasty.
Okay, so corneal transplant is a last resort for corneal edema, just like it is for corneal ulcers.
Exactly. But fortunately, if it's diagnosed and treated early, most people with corneal edema can maintain good vision.
Okay, let's move on to another condition that affects the shape of the cornea, but in a different way than astigmatism.
Keratoconus is a condition where the cornea gradually thins out and bulges outward, so it ends up shaped like a cone.
So instead of that smooth, rounded dome shape, it gets more pointy.
Exactly. And as the cornea thins and bulges, it can't focus light properly, which causes all sorts of vision problems.
What kind of vision problems?
People with keratoconus might have blurry vision, distorted vision, double vision, and they might see halos around lights. They might also be more sensitive to light and glare and have trouble seeing at night.
So it can affect vision in a lot of different ways. What causes keratoconus?
We don't know the exact cause, but it seems to be a combination of genetics and environmental factors.
So maybe there's a genetic predisposition that's triggered by something in the environment.
That's what we think. And it usually starts during puberty and progresses slowly over time.
So this is a condition that can really affect young people.
It can. And early diagnosis and treatment are really important for managing the condition and preventing vision loss.
How is keratoconus diagnosed? What are the signs an eye doctor would look for?
A comprehensive eye exam is the first step. And one of the key tests we use is called the Placido disc exam.
The Placido disc exam. What's that?
It's where we project rings of light onto the cornea and look at how they're reflected. In a normal cornea, those rings will look circular and evenly spaced.
But in keratoconus?
In keratoconus, those rings will be distorted. They might look oval-shaped or unevenly spaced because the cornea isn't smooth.
So it's a way of visualizing those bumps and irregularities in the cornea.
Exactly. We might also see these fine vertical lines in the cornea called Voigt's stria.
Voigt's stria, another sign of keratoconus.
Yes, they're caused by the stretching and thinning of the corneal tissue. And then there's the scissoring reflex, which is where the reflection of light on the cornea looks like it's scissoring or overlapping because of the irregular shape.
So those are the telltale signs. What about treatment? How do you manage keratoconus?
The treatment depends on how severe it is and how it's affecting the person's vision. In the early stages, glasses or contact lenses might be enough to correct the vision problems.
But I'm guessing regular contact lenses wouldn't work very well for keratoconus.
You're right. We often need to use special types of contact lenses, like rigid gas-permeable lenses or scleral lenses.
What's special about those lenses?
Well, they're designed to fit over the irregular shape of the cornea, and they create a new, smooth surface for the light to focus through. That way, the light can focus properly on the retina.
So it's like putting a corrective lens directly on the cornea. What about more advanced cases? If glasses or contacts aren't working, what other options are there?
For keratoconus that's getting worse, we have a procedure called corneal collagen cross-linking, or CXL.
Corneal collagen cross-linking, what's that?
It's a minimally invasive procedure that uses riboflavin eye drops and ultraviolet light to strengthen the cornea.
So like reinforcing that weakened corneal tissue.
Exactly. The goal is to slow down or stop the keratoconus from progressing.
Are there any other options besides CXL?
Another option is something called intacs, which are these tiny arc-shaped implants that we put into the cornea to reshape it.
So they're like little braces for the cornea.
That's a good way to think about it. And then, of course, in very severe cases where other treatments haven't worked, we might need to do a corneal transplant.
So corneal transplant is a last resort for keratoconus, just like it is for corneal ulcers.
Exactly. But with early diagnosis and treatment, most people with keratoconus can maintain good vision.
Okay, let's move on now to another condition that involves bulging of the eye, but in a different area than keratoconus.
Corneal staphyloma is a bulge or a protrusion of either the cornea or the sclera, which is the white part of the eye.
So this bulging can happen in either the clear cornea or the white sclera.
That's right. And depending on where the staphyloma is, we classify it into different types.
Types of staphyloma. Okay, let's break those down.
So we have anterior staphyloma, which affects the front part of the eye, involving both the cornea and the iris.
So that's a bulge that would be visible on the front of the eye.
Yes, it can be quite noticeable. Then we have intercalary staphyloma, which is located at the junction of the cornea and the sclera, right where the clear part meets the white part. And then there's ciliary staphyloma, which involves the ciliary body, the part of the eye that produces the aqueous humor.
Aqueous humor, that's the clear fluid in the front of the eye.
Right. Yes. And ciliary staphyloma can interfere with the normal flow of that fluid, which can lead to pressure problems inside the eye.
Okay, so we have anterior, intercalary, and ciliary. What other types are there?
We also have equatorial staphyloma, which affects the middle part of the sclera, and posterior staphyloma, which is at the back of the eye.
So there's a whole range of staphylomas depending on the location. What causes this bulging to happen in the first place?
Staphyloma is usually caused by thinning and scarring of the eye tissues. It's like a weak spot in the wall of the eye that bulges outward because of the pressure inside.
So like a balloon with a thin spot that's likely to bulge out.
Exactly. And anterior staphyloma, the one that affects the front of the eye, is often caused by corneal ulcers.
Those ulcers we talked about earlier.
Yes, when those ulcers heal, they can leave behind this thin, weak scar that's prone to bulging.
So it's another potential complication of corneal ulcers.
It is?
How is staphyloma diagnosed?
Well, an eye exam is the first step. A thorough exam, including a technique called ophthalmoscopy, where we use a special instrument to look at the back of the eye, is essential for seeing the staphyloma and figuring out how extensive it is. Sometimes we might need imaging tests like an ultrasound or an MRI to get a more detailed look.
So once it's diagnosed, how do you treat staphyloma?
The treatment depends on what type of staphyloma it is, how severe it is, and what kind of symptoms it's causing.
So a very tailored approach is needed,
Yeah.
just like with many other eye conditions.
Exactly. Sometimes all we need to do is manage the symptom. That might involve using eye drops to control the pressure inside the eye, or maybe pain relievers to help with any discomfort.
So just trying to keep things comfortable and prevent any further problems.
Right. But if the staphyloma is affecting vision, or if it's in danger of rupturing, then we might have to do surgery.
And what kind of surgery would that involve?
Well, it could involve trying to reinforce that weak spot with a graft,
Okay.
or in some cases, removing a portion of the eye to reduce the pressure.
So there are different surgical options depending on the specific situation, and early diagnosis and treatment are important to prevent those complications, right?
Absolutely. Catching it early and getting the right treatment can help preserve vision.
Okay. Let's go back to corneal infections for a moment, but this time let's talk about a different type of culprit, fungi.
Okay, so fungal keratitis is an infection of the cornea that's caused by fungi. It's not as common as bacterial keratitis, but it can be a lot tougher to treat.
Why is that? What makes fungal keratitis so difficult?
Well, fungi are different from bacteria in terms of their structure. Right. And they tend to be more resistant to the medications that we normally use for eye infections.
So the usual antibiotic eye drops won't work.
They won't. We have to use antifungal medications.
So it's like treating athlete's foot, but on the eye.
That's a good analogy. And just like athlete's foot, fungal keratitis can be pretty stubborn and hard to get rid of. Treatment often takes longer, and we might have to use both eye drops and oral antifungal medications.
Okay, so how does fungal keratitis even get into the eye in the first place?
Usually it happens after an eye injury, especially if there's plant material or soil involved.
So like getting poked in the eye with a tree branch or getting dirt in your eye?
Exactly. People who work in agriculture or gardening are more at risk because they're constantly exposed to potential sources of fungi.
That makes sense. What are the symptoms of fungal keratitis like?
They can be similar to other types of keratitis, pain, redness, tearing, blurred vision. But the corneal ulcer itself often looks quite different.
Oh, how so?
Well, fungal ulcers tend to be dry-looking and kind of grayish-white, and they often have these raised, feathery edges. You might also see what we call satellite lesions, which are these smaller, separate ulcers surrounding the main one.
So it's almost like the infection is spreading out in little pockets.
It does look a bit like that, and those feathery edges are a really characteristic finding that helps us differentiate fungal keratitis from bacterial keratitis.
So, bottom line, if you have any of those symptoms, especially after an eye injury involving plants or dirt, get to an eye doctor right away.
Absolutely. Early diagnosis and treatment are key to preventing complications like scarring or vision loss. And in really severe cases, we might even need to do a corneal transplant.
Okay, let's talk about a corneal condition that's not caused by an infection, but by problems with the eyelids.
Okay. Exposure keratopathy is damage to the cornea that happens when the eyelids can't close completely. So the cornea gets exposed and vulnerable to drying out.
So it's not getting that protection and moisture from the eyelids that it needs.
Exactly. Eyelids are really remarkable. They spread tears across the cornea, keeping it moist and clear, and they protect it from dust, dirt, all sorts of things.
They're doing a lot of work to keep our corneas healthy. And in exposure keratopathy, that protection's compromised.
It is, and that can lead to dryness, irritation, and the cornea becomes really vulnerable to damage. You can even get little erosions on the surface.
Little micro scratches, you mean?
Exactly. And if they get infected, they can turn into ulcers. Exposure keratopathy can actually increase your chances of getting a corneal infection.
That makes sense. What causes this problem with eyelid closure? Why wouldn't the eyelids close properly in the first place?
Well, there are a few reasons. One is lagophthalmos, which means the eyelids just don't close completely.
Lagophthalmos. What causes that?
Often it's caused by facial nerve palsy, which can weaken or even paralyze those eyelid muscles. But other conditions can cause it too, basically anything that messes with how those muscles work.
So even during sleep, the eyelids might not be closing fully, leading to dryness overnight.
Right, and that can be really harmful to the cornea.
Okay, so lagophthalmos is one cause.
Yeah.
What else can cause those eyelids to not close properly?
Another possibility is exophthalmos.
Exophthalmos, that's when the eyes bulge forward, like in Graves' disease, right?
Exactly. When the eyes are sticking out, it can be hard for the eyelids to cover the whole cornea, even if the muscles themselves are working fine.
So it's like the eyeballs are too big for the eyelids to cover them.
That's a good way to picture it. Okay, we've talked about causes. What about symptoms? What would someone with exposure keratopathy notice?
I'm guessing dryness would be a big one.
You'd be right. The eye might feel gritty, irritated, even painful. And that dryness can lead to other things like punctate epithelial erosions, those little breaks in the surface of the cornea.
Those little micro scratches again.
Exactly. And as we said, those can get infected and turn into ulcers.
Right.
So exposure keratopathy really makes you more likely to get infections.
Okay, so how do you manage exposure keratopathy? How do you protect that cornea?
Keeping it lubricated is really important. We use artificial tears, gels, ointments to keep the cornea moist and protected.
Okay. And for nighttime, when the eyelids aren't closing properly during sleep, what can you do?
A lot of times we recommend taping the eyelids closed at night.
You mean actually taping them shut?
It sounds a little strange, I know, but it really does work, and it can really help protect the cornea from drying out at night. We also use moisture chambers sometimes. They're like these little domes that fit over the eye.
So it creates a little humidified environment for the eye.
Exactly. And of course, treating the underlying cause is important too. If it's facial nerve palsy, treating that might help improve eyelid function. If it's exophthalmos, there might be treatments to reduce the bulging. The main goal is to get those eyelids working normally again so the cornea is protected.
Okay. Let's move on now to another condition that can cause damage to the cornea. But in this case, it's connected to a loss of sensation. Neuroparalytic keratitis.
Neuroparalytic keratitis is corneal damage that's caused by problems with the trigeminal nerve. This is the nerve that gives the cornea its feeling. And when it's not working right, the cornea can become numb.
So it can't feel if something touches it or if it gets hurt.
That's right. And that can be really dangerous because the cornea is vulnerable to injury, and the person might not even realize it's happening.
So they could get a scratch on their cornea and not even feel it. Wow, that's a little scary.
It is. And without that pain signal, they might not get treatment, which can make the damage worse.
So why would the trigeminal nerve get damaged? What causes neuroparalytic keratitis?
There are a few possibilities. It can be caused by trauma to the eye or the head, surgery around the eye, injections near the eye, and even some infections like herpes zoster, the virus that causes shingles.
So lots of things can disrupt the nerve's function.
Yeah.
What are the signs and symptoms of neuroparalytic keratitis?
Well, the main feature is that loss of sensation in the cornea, but that can be hard to test, especially if the person's unconscious or can't tell us what they're feeling. So a lot of times we rely on how the cornea looks.
What would you see on exam?
The cornea might look kind of dull or hazy, and we might see those epithelial defects, those little breaks in the surface.
Like those tiny scratches we were talking about with exposure keratopathy.
Similar, yes. But in this case, the person wouldn't feel any pain from those scratches because the cornea is numb.
Okay, so the cornea is basically anesthetized. How do you treat neuroparalytic keratitis?
The most important thing is protecting the cornea from further injury. Lubrication is really important, using artificial tears often to keep the cornea moist. We might also patch the eye to shield it, and in some cases, we do a procedure called tarsorrhaphy.
Tarsorrhaphy, what is that?
It involves partially sewing the eyelids together, so the eyelid opening is temporarily narrowed to protect the cornea.
So less of the cornea is exposed to prevent further damage.
Exactly. It's temporary until the corneal sensation comes back.
Okay, let's talk about another condition that affects the vitreous humor. Vitreous hemorrhage.
Vitreous hemorrhage is bleeding into the vitreous humor, that gel-like substance that fills the back of the eye.
So instead of being clear, that gel fills up with blood,
Right. And that blood can interfere with light passing through the eye.
causing vision problems, I imagine.
Exactly. It depends on how much bleeding there is, but people might see floaters, have blurred vision, or even lose their vision completely if there's a lot of bleeding.
So those little specks or cobwebs that some people see floating across their vision, those can be a sign of bleeding in the vitreous.
They can. It's important to watch out for any sudden increase in floaters, especially if you also see flashes of light or lose some vision.
Okay, so what causes vitreous hemorrhage? What makes those blood vessels in the back of the eye start to bleed?
A few things. One of the most common is a retinal tear or detachment.
Ah, retinal detachments. We were just talking about those.
Right. When the retina tears or detaches, those blood vessels that supply it can rupture, and blood spills into the vitreous.
So another potential complication of retinal detachment,
It is. Trauma to the eye can also cause it.
like getting hit in the eye or a sharp object poking the eye.
Exactly. And certain vascular conditions like diabetes and high blood pressure can increase the risk too.
It seems like diabetes and hypertension come up with a lot of eye problems.
They do. They both can damage those delicate blood vessels in the retina, making them more likely to leak or bleed.
Okay, so retinal tears, trauma, and vascular disorders are all potential causes of vitreous hemorrhage. How do you treat it?
The first thing is to find out what's causing the bleeding. Once we know what's making those vessels leak, we can treat that problem.
So if it's a retinal tear, they might use laser surgery to seal it. And if it's diabetic retinopathy, then controlling blood sugar would be really important.
Exactly. Addressing the root cause is always the first step.
Right. But what about the blood that's already in there? Does that clear up on its own?
A lot of times, yes, the body will reabsorb that blood over time, like a bruise on your skin that fades away. But if it's a lot of blood or it doesn't clear up on its own, we might need to do a vitrectomy.
Vitrectomy, that's that procedure where they remove the vitreous and replace it.
Right. Yes. It's the same procedure we use for some retinal detachments.
So they're cleaning out the bloody vitreous and replacing it with a clear fluid so light can pass through.
Precisely. That can dramatically improve vision for people with severe vitreous hemorrhage.
Okay. Let's move on to a condition that involves inflammation of a different part of the eye. Scleritis.
Scleritis is inflammation of the sclera, that tough white outer layer of the eye.
So different from conjunctivitis, which affects that clear membrane that covers the white part.
That's right. Scleritis is deeper, affecting the sclera itself.
And that can be really painful, right?
It can. People often describe the pain as this deep, boring ache that can even spread to the head and face.
So more than just an eye ache.
Yes. And people with scleritis might also have redness, tearing, and sensitivity to light.
Those symptoms sound pretty rough.
They can be. And what causes scleritis? Well, a lot of times we don't know. We call it idiopathic.
So no identifiable trigger.
Right. But other times it's linked to autoimmune diseases like rheumatoid arthritis, lupus, or inflammatory bowel disease.
So the body's attacking its own sclera.
Exactly. It's another example of a systemic illness affecting the eyes. And infections can sometimes trigger scleritis too, but that's not as common.
Okay, so idiopathic, autoimmune, and infectious are the potential causes. What about treatment?
Treatment depends on how severe it is and what's causing it.
So a personalized approach again.
Exactly. For mild cases, over-the-counter pain relievers like ibuprofen or naproxen might be enough. But for more severe cases, we often use corticosteroids, those strong anti-inflammatory medications. We can give those as pills or eye drops.
And if it's connected to an autoimmune disease, then managing that would be crucial.
It is. That might mean using medications to suppress the immune system so it stops attacking the sclera.
Okay, so pain relievers, corticosteroids, and maybe immune-suppressing drugs are all options. And early treatment is important, right?
It is. Untreated scleritis can make the sclera thin out, which can bulge and form a staphyloma.
Ah, those staphylomas again. So scleritis can lead to those.
It can. And it can also lead to glaucoma, damage to the optic nerve, and even vision loss if it's severe.
Definitely a condition you don't want to ignore.
Right. Early diagnosis and the right treatment are really important to prevent those serious complications.
Okay. Let's finish up our deep dive into ophthalmology with a final condition. Endophthalmitis. This one sounds pretty concerning.
Endophthalmitis is a serious infection of the inside of the eye.
Inside? Wow.
It can affect a few different structures, including the vitreous humor, the anterior chamber, and even the posterior chamber sometimes.
So it's widespread inside the eye.
It is, and it can be a real emergency. It can threaten your vision.
Threaten vision. You mean it can cause blindness?
It can if it's not treated quickly and aggressively.
Okay, what causes endophthalmitis? How does an infection like that get inside the eye?
Two main ways. It can be exogenous, meaning the infection comes from outside the eye,
Okay.
or it can be endogenous, meaning it spreads to the eye from somewhere else in the body.
So exogenous would be like after surgery or an injury that punctures the eye.
Exactly. Anytime those defenses the eye has are broken, bacteria can get in and cause an infection.
And endogenous would be like bacteria traveling through the bloodstream from an infection somewhere else.
Precisely. Certain types of bloodstream infections can do that.
Okay, so from the outside or from within the body, what are the symptoms of endophthalmitis?
The classic ones are pain, redness, decreased vision, and often a whitish or yellowish discharge.
So pain, inflammation, and problems seeing.
Exactly. And those symptoms usually come on quickly and get worse fast.
So you shouldn't wait to see if it gets better.
Absolutely not. Endophthalmitis needs treatment right away.
How do you treat it?
The main treatment is high doses of antibiotics. We usually give them both intravenously and also inject them right into the eye. That way we can make sure the medication gets to the infection as fast as possible.
So attacking those bacteria from two directions.
Right. And sometimes we need to do surgery as well, usually a vitrectomy.
Vitrectomy seems to be used for a lot of problems with the retina and vitreous.
It is. In cases of endophthalmitis, we do the vitrectomy to remove the infected vitreous and any debris that might be making the inflammation worse. It's kind of like a deep cleaning for the inside of the eye.
Well, that brings us to the end of our deep dive into ophthalmology. We've covered a lot of ground, exploring all these different parts of the eye and all the things that can go wrong.
We have. It's fascinating how complex the eye is.
It really is.
Yeah.
And it's so important to take care of our eyes. It seems like so many things can affect them.
They can. But thankfully, we have ways to diagnose and treat most of these conditions. And the earlier we catch them, the better.
That's a great point. Regular eye exams are so important, even if you think your vision is fine. Early detection is key.
I agree.
Well, thanks for joining us for this deep dive into the world of ophthalmology. And remember, if you have any concerns about your eye health, don't hesitate to see your eye doctor.